So in our part one, Dr. Elorriaga just started to establish a foundational framework for progressing to his case presentations. So this is our part two, which of course will also be recorded, and will follow the same format. So Dr. Elorriaga will present, and if everyone can put their questions in, like type them in the Q&A box below. At the end of his presentation, we'll have a bit of a Q&A session, and I'll make sure that I get to all those questions so that we get answers for this one, and then everyone will be sent the recording afterwards. All right, this is going to be a very short intro, so we'll get started right away.
Thank you, Sue. I will jump in and reiterate what you just said, that we are building everything towards a series of case presentations. I think we will need several cases, different body parts, to appreciate the differences in some of the dimensions involved in the pain with movement disorder. So that will come. So you're going to have me here for a while. I like to start, as always I do in my own on my own practice, with a summary of what we did last time. Key ideas in part one, including the fundamental question in clinical practice, which is not the diagnosis, surprisingly, but the where to treat. In order to treat, we need targets. And the pursuit of the target, the best selection of the best target, is the goal of all this process. The other goal is to have a tool, clinical tool, to allow us to handle the complexity of the human body, the complexity of the pain problems, because we established that pain problems are brain events, and these individual neuromatrix of billions of neurons, trillions of synapses acting in a unique manner is impossible to analyze digitally, to analyze analytically. Instead, we need a methodology that can lead to this selection of targets, which today, at some point, is going to be the core part of the presentation, what I call goals, targets, and inputs. So we established as well that there are many contributors to the pain experience. The main one, obviously, is peripheral nociception, but it's not the only one, and it is not the main one in lasting pain problems. In acute problems, yes, peripheral nociception is the main contributing factor, but usually neuropathic behavior of some sort of both either the peripheral nervous system and the central nervous system are important parts of this pain puzzle that we use as one of our analytical tools to figure out what is the nature of what we are dealing with. And we established as well that the biological value of pain that has neuropathic component is very low, and it no longer reflects any particular structural damage. Oftentimes, people with pain have no particular structural findings, and people with structural findings may not have any symptoms. I put on the table a very important concept I like to reiterate, which was the concept of the nervous system as a glandular system that secretes two kinds of substances, neuropeptides and neurotransmitters. And I caught myself on a mistake reviewing the material. I said neuropeptides were smaller when indeed they're bigger molecules. Not a big deal, but they're bigger than the neurotransmitters. They also have longer lasting effect. They also have a presence all over the nerve, unlike the neurotransmitter, which is found in the presynaptic vesicles and across the target, where it's going to have a short acting that is going to trigger a depolarization, which is the goal of the neurotransmitter. At any rate, they're both peptide-based substances, but the key concept, again, is the nerve secretes. Not only depolarizes, because many tissues in the body depolarize, but secretes. And this secretion can be triggered by irritation. Irritation is a non-denominational concept, and it stems most likely from perfusion issues, nutrition, cellular nutrition, which typically will occur in areas of articular dysfunction. The mere fact that we don't move the intervertebral joints appropriately, unless we are practitioners of Qigong or yoga, or athletes doing routines that involved extension, flexion, rotation of the spine. In general, the common person does not maintain a good articular function of the intervertebral joints, the zygapophyseal joints. And this leads, in my opinion, to a situation of lesser perfusion. And this lesser perfusion somehow irritates the very metabolically active and delicate sensory neurons that live in the dorsal root ganglia. And these cells will secrete substances that we call neuropeptides, that they are vasoactive. And these substances will be deposited at the end of the axonal prolongation at the receptor site, and they will produce vascular events, particularly plasma extravasation. Plasma will come out of the vessels because the body will believe that there is a threat and it needs to deploy substances that come with the blood, such as macrophages, cells from the reticuloendothelial system. And this plasma extravasation is akin to a flood in the town. The flood will eventually be absorbed, the liquid part, but it will leave behind a lot of garbage on the streets. If you ever seen the images of a town after a flood, is what I call the mud after the flood. That, in terms of the human body, is what we call the trophy edema, the trophic changes that are easy to find by palpation on, particularly on the paravertebral area. That will be one of our main clinical tools. A simple palpation, a pinch roll of the skin will determine the thickness, the pliability, whether the skin slides or is stuck, because all that garbage has made the layers stick to each other. And this is a well-known phenomenon, and we call it neurogenic inflammation, and is truly, truly at the core of most slow onset pain problems, and is part of what we can call, in non-denominational terms, segmental dysfunction, or what the osteopaths call osteopathic lesion, or the chiropractors chiropractic subluxation, or the French manual medicine school, painful minor intervertebral dysfunction. At any rate, something is wrong at the segment, and that something triggers in the periphery of the tissues supplied by that segment a neurogenic inflammation at the dermatomal, particularly dermatomal myotomal level, which triggers events such as hypersensitivity and even refer pain. Very, very important concept that we will review. Therefore, as a corollary to this, segmental modulation already we know is mandatory in the treatment of any pain problem, regardless of where the pain is felt. And that means that we need to know very well the levels of innervation of every body part, every part of the body. And that refers to the embryological development of innervation and the corresponding layers at the somatic level, dermatome, myotome, sclerotome. The other concept that was built as well was that the nature of most pain problems is chemical, not mechanical. That's very, very important. We're so used to identify pain equals structural damage, and that is not true, not statistically true. And you can try to prove me wrong with the literature. Most pain problems are chemical, and they are due to this contribution of the neurogenic inflammation plus other local phenomena. Most pain problems obviously are multidimensional, and that's why we need a broad understanding of both the pain puzzle that we call, meaning what goes on with the nervous system, peripheral, spinal, and supraspinal levels, and we need to learn to bridge the clinical gap, meaning the events that are occurring in different parts of the body at different levels, neurological, metabolic cellular, interstitial tissue, interstitial fluid dynamics, and try to understand how then the brain event is created by this neuromatrix. You have 3 articles where all these 10, 11 contributors are explained in detail, and you will be provided with a file at the end of these presentations or at some point with these 3 articles plus another 4 explaining the foundation of the neurofunctional operating system. So I will not get into each of these in detail. To finish the summary, we also discussed the different subdivisions of the nervous system, somatic nervous system, which is the one we have more access, the somatic and the sensory. The sensory is very complex because it has exteroception, interoception, proprioception, plus nociception. And then we have the autonomic, and with different nerve types of nerve fibers, with different receptors, etc. Also, we discussed the autonomic nervous system, the sympathetic, parasympathetic, and specifically on the sympathetic side, we talk about levels of innervation of the vascular system between T1 and L2, and we talk about the overlap of the visceral innervation with this vascular innervation, and we also briefly talk about the vagus nerve. And finally, we discuss science about acupuncture responses, which we summarize in 3 levels. When you put a needle, something happens on the area of the needle. That's a local response. Something happens on the segment where the information arrives from that dermatome, myotome, sclerotome. That's the segmental level of response, which is complex. One we discussed was the gate control, which is information from thick myelinated neurons, inhibits information from small unmyelinated or small myelinated A delta fibers, the gate control. But also there are other mechanisms such as descending and facilitatory or inhibitory systems, and also there's an array of suprasegmental signals that's extremely complex. Some are neurological, some are neurohumoral. And finally, we concluded with a slide that summarized these effects and led to the possible uses of acupuncture. So I believe this was the last slide. This was the last slide of the presentation. And we will now resume our quest for clarity in the selection of treatment target. We understand that the physiological responses to needling are sufficient to to find applications of this modality in acute and chronic musculoskeletal pain and dysfunction, or even neuro dysfunction of miscellaneous type. Functional disturbances, which could be reversible, such as transient indigestion or dysmenorrhea during the menstrual period, or unreversible functional disturbances such as old age decay, or situations cancer or connectivopathy or other things. But in order, rather than trying to use formulaic approach, which is not, as you know, my forte, I believe in understanding, and understanding the effects will help us select the effects that we want to maximize, and then we can use the appropriate techniques. So this, to me, is the most important of all the slides that I presented, because that is the summary of what can be accomplished with the needles. On yellow, after the dot, I have written the effect that the needle could provide, and in red, the physiological change that can be expected from that physiological response. And I've put them in the order I believe should be considered. So in my book, in my treatments, forever and ever, my first intention, my first goal is to, improve perfusion. Why? Because perfusion is the necessary process to bring oxygen, nutrients to the cell. And without that, there is no metabolic activity, no optimal activity. And what is the physiological change we need to achieve to improve perfusion? Well, I already shown some studies that prove that the needling improve or produce vasodilation, which I like to put in a non-denominational manner, improves vasomotor control. At the end of the day, the vascular system, the arterial system, is a set of muscles, hollow muscles. And these muscles, like the somatic muscles, could suffer a spasm. You know, when they're fatigued, they don't relax properly. Spasticity is due to energy crisis and among other things. So if we can improve vasomotor control, we can improve perfusion, and that will solve a lot of problems. So in my opinion, every time we treat, we should select what tissues we want to get better perfusion, like those rats that had the needles around the knee and demonstrated, even though they were anesthetized, to improve mean arterial pressure. And it was a combination of nitric oxide release as well as autonomic reflexes. So this is all science-based. First effect, improve perfusion. Second effect, which is very useful in my field, which is sports medicine, but also for the common person experiencing a pain problem, is improve strength. How can we do that? Well, we cannot really make people stronger above their baseline. What we can do is allow them to reconnect with their motor system Because, as the literature demonstrates and clinical practice demonstrates, the most universal finding in pain problems is, apart from the pain, what we can call neuromotor inhibition, meaning the, the system has lost connectivity between the central nervous system, the spinal cord, and the muscles, the effectors of the motor signals that stem from the premotor and motor cortex. So this is not a true improving strength, is recovering the access to your motor system. If you can do these two, improve perfusion and improve neuromotor activation, you're going to be able to handle movement, to handle reaction forces, and certainly nociception is going to decrease by leaps and bounds. And in my book and in my practice, I do not seek pain modulation. I let the brain do that. I seek modulation of the universal dysfunction of poor perfusion and neuromotor inhibition that is being demonstrated in any pain problem. In addition, I believe that the arrival of good signals, signals triggered by the needles plus the electrical stimulators, the arrival of these signals at the segment improves in a non-denominational manner everything that the segment handles, which is articular, muscular, vascular, visceral function. And this is also demonstrated through many experiments in the literature. So the mere fact that we send signals that are non-painful, also that are signals from high level receptors and fibers, thick myelinated fibers, makes the segment to pay attention to those and helps modulate that integration of signals that is integral part of the functionality of the segment. The segment, remember, was the third step in the events that the nervous system carry on, from transduction, transmission, modulation, and then perception once it reaches the central nervous system. So if you can improve, if you put needles anywhere without causing pain, that per se has a beneficial effect on the segment that will help, as we know based on empirical evidence, will help anything of articular, muscular, vascular, or visceral nature, functional, obviously not pathological. So these three are absolutely powerful ways of improving function, and usually they lead to a painless activity, because oftentimes pain is just lack of oxygen for the peripheral receptor or the peripheral nerve, overload of certain muscles because of neuromotor inhibition of some other muscles, and lack of modulation of filtering of signals at the segment because of lack of good signals arriving at the segment. When you fix that by sending the right signals, then you fix the dysfunction, pain disappears. Because the brain doesn't consider that needs to pay attention to that anymore. Then we have a powerful effect at the local level, obviously, where you put needles near tissue that's healing, that's damaged. You stimulate a bunch of processes that lead to tissue healing, that activate local cell metabolism and improve tissue remodeling and decrease adhesions. We know that. When I have athletes with tears, I treat daily, even sometimes twice daily, and the healing there studies as well with fracture model in dogs and rabbits, demonstrating that repeated electroacupuncture is a promoter of better tissue healing, whether soft tissue or bone. All these effects, as you can see, have not involved pain. I think one of the, or the fundamental mistake in the pain industry is precisely to focus on pain, because pain being a brain event is very far from our reach. We cannot get into people's brains easily, and and it's too complex to target it there. It's much better to target the dysfunctions that are universal associated with these problems, and then let the brain modulate the signals itself. But you have also two additional goals and strategies. You can decrease pain perception simply by modulating nociceptive signals. For instance, in an acute tissue damage, you can put needles, you can put ice, you can use other means, and you can decrease nociceptive signaling, and that will decrease the amount of spinal arrival of nociceptive signals, and that will therefore decrease the amount of signals that go to the brain, and that will decrease the pain perception. And that's interesting in acute situations, but beyond that, it is not really such a good strategy. It's much better to improve perfusion, restore strength, promote modulation at the segment, and improve any tissue processes that need to be helped. And obviously, the same strategy to decrease pain perception that we use via nociceptive peripheral receptors, we can use simply sending low frequency signals to the brain and triggering the very well-known reflex of secretion of beta endorphins and certain dynorphins, and that also will modulate the pain perception. But this is akin to the volume of the radio. Yeah, we can turn the volume down, but it would be better to change the station and stop that annoying program. That's really what's bothering us. So I think it is a much inferior strategy, and frankly, over the years, I almost don't pay any attention to pain, which I confess, because I think is culturally already too, we pay too much attention. We allocate too much value that I think is improper if we contextualize pain as a universal signal that all animals experience, and that it has a biological value when it's acute and due to tissue damage, but has no value when it's purely functional neuropathic and due to abnormal metabolism of the nerve. So please study this slide, and it will become your best friend when it comes to the goals, targets, inputs game, which is what I want to play with you today. Secret number 3 is very simple. Nerve cells are accessible via their peripheral axons and their receptor sites on tissues. So physically, we can contact the, the nervous system via their axons, which we see here, a full peripheral nerve anatomy represented, very important, and also Here I gave a summary of all the type of both sensory and motor innervation. So the corollary is we have to learn peripheral nerve anatomy. We need to be conversant on the type of nerve fibers and receptor sites. So here, very important concepts for all of us to remember when interpreting what's going on in the periphery, not just with the patient experience. We need to study one thing that I will not get into today, which is called fascicular anatomy. Fascicular anatomy refers to this. The fascicles are the groups of axons that are packed into the nerve, and these fascicles are not constant throughout the length of the nerve, but in order to protect the neurons and minimize the damage that could occur in the periphery if all the fascicles were the same from beginning to end, they mixed and mingle. Therefore, if we damage one fascicle, the damage will be spread out in different areas, not on one area. That's a very interesting anatomical detail. Fascicular anatomy varies. Number of fascicles and position of the axons along the nerve trajectory. Also, you know that everything is wrapped here into connective tissue, endomysium. Every individual axon has endomysium. Then we have, sorry, endomysium is the muscle, endoneurium. Then we have perineurium, which wraps every fascicle group of axons. And then we have the epineurium, which covers all. In between, we have vessels, and we have also other nerve branches that are not part of the nerve proper. And these two dimensions are extremely important. Using their Latin denomination, the vessels of the nerves are called vasa nervorum, and the nerves of the nerves are called nervi nervorum. So this nervi nervorum and this vasa nervorum oftentimes are the origin of the dysfunction that produces a nerve problem without the nerve having any structural, microstructural problem. And these nervi nervorum have been associated with neuropathic pain. So I invite you to do some reading on this topic, nervi nervorum, and understand the difference between a problem that comes from an axon that is part of the nerve. For instance, if this was a median nerve, an axon that supplies either the thinner muscles or the skin on the medial part of the hand, that would be one type of problem. Or there's a problem with perfusion, therefore these axons that are healthy otherwise don't receive enough oxygen, enough nutrients, and then they start complaining without having any problem. So the nerve can give always two different kinds of nociceptive phenomena. One that stems from the axons proper from the nerve, and one from the nervi nervorum. Also, I like to pay a little bit of attention to this table. And on the right-hand side, we have the sensory classification, the double sensory, A, B, C, and then 1, 2, 3, 4. Each one means different things, and they're both utilized. It doesn't matter now where it comes from. So we know that the fibers should be organized from diameter, from thicker to thinner, and that diameter determines the speed. The thickest are the fastest. So the thickest fibers, about 22 micrometers, are able to conduct 120 meters per second, which is a very fast speed. And obviously, these type of fibers on the motor side are the normal motor neurons because the body needs to activate the muscles quickly, fast. But also in terms of sensory, the information from precisely the muscles that need to be contracted fast, also the brain needs information about tension, rate of shortening or lengthening, etc. And muscle spindles and Golgi tendon organs are also innervated by thick myelinated sensory fibers, which are called 1A, 1B, similar to this A alpha. If we go to the next level, which already is a significant drop in speed from 120 meters to 70 meters, but still very fast, we find at the sensory level, particularly, some of other parts of the spindle, and also temperature, pressure, and Pacinian corpuscles, which are mechanoreceptors. So what is clear from this table is that for the body, the priority, the absolute priority is movement and control of the movement. If we continue, we still find something that has to do with the muscle, intrafusal fibers that you know they are part of the muscle spindles. Sorry, this is the full table. Maybe here you can see it better. The muscle spindles as well, and that are the type 3 receptors. And only then at the level of 5 micrometers, which is a 1/4 of the diameter, and the speed is much less. 15 versus 120 is 10 times, almost 9 times, 8, 9 times slower. That corresponds to the A delta fibers, which equivalent to the type 3 sensory receptors that are involved in mechanoception, but also could be involved in contributing to a pain experience. It would be the fast pain, the sharp pain. Typically, A delta fibers innervate fascia, and it's the pain that we have even when we put a needle with no great technique, and then it feels very sharp. That sharp signal is being transmitted by an A delta, a small myelinated fiber that has no encapsulated receptors. Finally, at the bottom of this table, and I'll go back here, at the bottom of the table, we have the C fibers, which are 70% of all the fibers of the body, which are 100 times or, well, 60 times slower and 20 times thinner and have no myelin. And these are the so-called pain fibers sometimes, although that's improper. There are no pain fibers. They are nociceptors. So if you look here, you realize that for the body, pain is truly not a priority. And it makes sense because the system, in order to operate properly, what it needs is a great deal of harmony, coordination between all these mobile parts. Something that moves is not easy to handle. If you drive a car, if you drive a motorbike, you know it. And pain, I make it akin to an alarm, a fire alarm in the building. Pain is something to call your attention, but not to give you particular information. When the fire alarm rings, you don't know whether the fire started on the second floor, the first floor. You don't know whether it was electrical, chemical, arson. All you know is that you have to get out of the building. And therefore, I like to break an important myth related to pain, and it's the fact that pain is never, was never intended to have a high topographic value. Therefore, stop allocating topographic value to pain. It may hurt a lot here in this particular point, but that doesn't mean that there is nothing, anything there. And I know that's intellectually a challenge, but empirical evidence will quickly get you there. Peripheral nerve anatomy is something you have to really understand, because when you select a target, an input, and put an input, you're going to have to be crystal clear about where you want the signals to end, which segment, and the willingness of the nerve that you are engaging to transfer your signal. Oftentimes, you will not be able to use the affected nerve. Let's say that you have a problem on your femoral nerve territory, on your anterior thigh. Therefore, it precludes the idea of going to that nerve and trying to send signals to the L2, L3, L4, which are the levels from which the femoral nerve comes. But not only comes from this, it comes specifically from the posterior division to the anterior primary rami of this level. And the femoral nerve has a cousin that's called the obturator nerve that also comes from L2, L3, L4, but in this case from the anterior division of the anterior rami. So to know this division, anterior primary rami, divide into anterior divisions and posterior divisions. Anterior divisions innervate flexor muscles, posterior divisions innervate extensor muscles. The leg is like an arm that's twisted. Therefore, the anterior part of the leg really is the extensor side, not the flexor side. That's why you have to master anatomy at every level before you can design the ideal acupuncture treatment. But going back to the example, it would be totally, sorry about that, totally legitimate to send signals via the obturator nerve in order to modulate activity that's taking place on the territory of the femoral nerve, because at the end of the day, the same lumbar segments are going to process the signals from both sides. And not surprisingly, the knee innervation, for instance, which is one of the applications of this concept, the main articular nerves for the knee, which we will review at some point, articular innervation, very important and neglected area of neurofunction, receives two main branches, one from the femoral, one from the obturator. And this is so typical that, for instance, before the age of 15, many teenagers experience knee pain that is really hip pain via activity of the obturator nerve, and due to the incomplete maturation of the nervous system. So knowledge of neurofunction, articular innervation, is mandatory to arrive at a mapping, neuromapping of the problem that is going to help select the appropriate targets. So we know the secret number 4. I'm looking at the clock. I'm going to go just 5 more minutes. The secret number 4 is that the somatosensory axons, apart from we know the nerves, are associated with specific tissues. So we know which nerve, which axon innervate the C5 myotome, which is the C5 via the axillary nerve. We also know that the C4 dermatome here, C4, it comes via the supraclavicular nerves, which are part of the cervical plexus, not the lumbar plexus. So in treating shoulder problems, we will discuss eventually you have to go from C2 all the way to T7 really to cover the two somatic levels involved, cervical plexus, lumbar plexus, plus the innervation of the vessels. And then finally, the sclerotomal level is provided by branches from the axillary nerve as well as other nerves, the suprascapular nerve particularly. So we need to learn this dermatome, myotome, sclerotome, as well as visceral innervation, because also shoulder could be refer pain from viscera, subdiaphragmatic viscera, whether gallbladder or liver, as well as from the lung and from the pleura. And without this knowledge, it's impossible to do a good working diagnosis of, or not diagnosis, but mapping of the possible contributors to that pain experience. So finally, the peripheral nerves and the receptor sites are accessible to the acupuncture needles and to the electricity. And it's our task to learn the location of all these neuroreactive sites and the palpatory anatomy, which is going to be the topic that will finally get us to the treatments, which is goals, targets, and inputs. Goals are simple. Goals are what do you want to improve? Okay, I want to improve perfusion on the shoulder area. I want to improve strength on the shoulder area, just to keep it general. I want to improve segment C2 to T7, as I said. I want to improve, there's a little tear of the subscapularis. Well, I want to improve tissue trophism, and I want the body to modulate signals peripherally and centrally. So these are goals. Now, targets are going to be those nerves involved in the innervation of those structures. And for that, we will have to know, okay, supraclavicular nerves, axillary nerve, suprascapular nerve, etc. Every single nerve that's on the area. And then finally, with that information, we can generate inputs, which is what we see here. This is an input. And the input is targeting. It's redundant, but it's the way it is. The input is targeting one part of the target, because if the target is a nerve, the nerve is very big. And then you're going to select preferential areas to access, which I will discuss, and I will go over this in detail in the next presentation. The next presentation is going to be exclusively on goals, targets, inputs, how this process from an analysis, I will show you how to use movement to do this, simply mapping. Okay, if there's a problem with abduction, I determine what muscle participates in abduction, deltoid and supraspinatus and long head of the biceps. Which nerves innervate these muscles? Axillary, suprascapular, and musculocutaneous. And then how can I access these nerves in the best area and insert the needle comfortably and provide an electrical stimulation? And that would be the discussion, from goals to targets to inputs. And for that, I develop a whole standardized methodology, which is the neurofunctional acupuncture methodology with local inputs, segmental or axial inputs, and systemic regulatory inputs, each one with different goals and targets, and obviously different placement, different location of the needles. So I think we've been going only 38 minutes. So you tell me, I can keep going. We can go to questions. as today is a transition day in the information, very important.
Let's see if there's any questions first, and then if we've got some more time, we can keep going a little bit. So for the moment, there's no questions, so you can keep going.
Okay.
Okay.
Again, it is important for me that everyone listening understands the ultimate goal. The ultimate goal is we're going to put needles on the best possible neuroreactive sites in order to achieve the intended goals. Now, when I started developing this, I realized something. I realized that due to the organization of the nervous system, there were these three main areas that I could consider in everything, diagnostic or treatment. The local peripheral segmental level, the spinal segmental level, which could be dermatomal level, myotomal level, sclerotomal level, or visceral innervation, or sympathetic vascular reflex level. And then I could also consider the many areas of processing signals above the spinal cord, so suprasegmental levels, thalamus, hypothalamus, sensory cortex, somatosensory cortex 1, somatosensory cortex 2, etc. So I had a very good neuroanatomy professor. I studied neuroanatomy for 2 years in medical school, 5 hours a week of class and 5 hours of lab. A really in-depth. My professor had written a very thick book that I had on where he described every pathway of every nerve and every kind of sensory or motor information carried by each nerve, something that resulted very useful later on. Also, I realized that there was a neuromodulatory activity constantly going on. We can see it here, where the brain would not allow just any information to get there, but would have multiple mechanisms of filtration. And this is something we need to get crystal clear. What reaches the brain is not absolute, is just the product of this modulation processes at the spinal cord, which are influenced by entry signals. For instance, this Pacinian corpuscle, a beta fiber, is sending a presynaptic inhibitory signal to the nociceptive information that these C or A delta fibers are sending to the same segment. So the fact, for instance, that you have damage and now some neurons are sending nociceptive signals, but you keep moving, which happens during athletic competition, that makes pain less because makes nociception less. Then when you stop and this information stops, there is an increased nociception, and then obviously is a lot more painful the next day than it was during the game. And you can't believe it because say, oh, I kept running. Yeah, you kept running, and that helped modulating. This is the gate control. But also, when these signals proceed upstream via these three spino-reticular tract, spinomesencephalic tract, and spinothalamic tract, each of these tracts also sends collaterals to different levels, to the medulla oblongata, to the pons, to the midbrain, and those signals generate descending signals that go back to the same level where the nociception entered. So here you have the raphe spinal tract, the cerulospinal tract, the tract between periaqueductal gray and the locus coeruleus, etc. So there are several descending, several descending inhibitory, in principle, they're inhibitory signals to further filter. This is like mid managers that question the segment. Is like, hey, is this information you're sending so important? Are you sure? Because they don't want to bother the brain if the information is not critical. So you can better understand then the fact that there's no proportionality between the original injury and the amount of signals that the brain is going to receive. It depends on many factors, and these are just the automatic ones that happen on the way up of the signals. But then the signals reach this famous periaqueductal gray, which is a nucleus in the base of the brain that will trigger the secretion of beta endorphin that will go to blood and cerebrospinal fluid and will serve as a modulator of the pain experience. That's what Bruce Pomeranz discovered. That was the experiment was elegant and brilliant. Bruce thought, okay, is there something in the animal that has received acupuncture that can be transmitted to another animal? Very good question. So they did acupuncture in the rat. The flick tail latency decreased, showing that the rat was not as bothered as before the treatment, and then extracted blood from that rat, injected that blood in another rat, and surprisingly, the other rat also decreased the flick tail latency in response to a noxious stimulus, proving that there was something in the blood that had been triggered by the acupuncture treatment. And that was the end of speculation about the scientific nature of acupuncture, because it demonstrated that there was a neurochemical process that was involved. And after that, there was a major development in understanding these pathways, and also then Jin Henshan, a Chinese researcher, worked on the different frequencies and demonstrated that different frequencies trigger predominantly secretion of different neurotransmitters, and low frequency 1 to 4 hertz triggers mostly beta endorphin. 15 hertz triggers some dynorphins. I can't remember, it's BA, it's immaterial. At the spinal cord, 80 hertz is the peak secretion of GABA, gamma aminobutyric acid, at the segment, which is the basis of TENS, the TENS machine. The TENS to work has to be in the segment that's sending the nociceptive signals. Then 150 hertz involve descending serotoninergic and noradrenergic systems, the monoamines, and then higher frequencies involve miscellaneous. So we know all that. This is all published in the literature, and there are people who like to play with this. I personally don't do it a lot. There are even machines designed combining. The Swedish developed a machine many years ago combining low frequency with mid frequency. Another program low frequency with 125, 150, etc., trying to produce secretion of several neurotransmitters. But in my opinion, that's like playing only with the volume. And I like to change the channel. And to change the channel that you don't want to hear, you have to go to the other level of analysis, the one that we will develop in the next sessions, the neurofunctional operating system, how to understand the neuromotor dysfunction, the neurosensory dysfunction from a true functional standpoint, and therefore being able to select the best targets and try to restore functionality, perfusion, neuromotor, vasomotor activity, integration, segmental integration of signals, rather than playing purely with pain. So I think that's a good point to stop and listen to the possible questions, and we'll take it from here, and we'll continue developing all the levels of complexity that are very many involved in our fantastic method of treatment, which is these fine solid needles plus the electrical stimulators.
Thanks very much for that. Let me see here. Thanks everyone for joining us on your lunch break. I know some of you have to run. Let's see if there's any questions. I think people are looking forward to your next part, Dr. Alejandro.
It's okay. It's a process, and it's a slow process, but we'll go layer by layer. We'll go back, see what we've done, where we at, and then clarity will come later on. Now you have to embrace, like any learning process, you have to embrace the discomfort that's testing my new motorbike these days here in Spain. And even though I have experience, I'm not comfortable yet. I'm getting used to it. I'm in a absorbing mode. So that's part of any learning process.
There was one question. Are different hertz more effective on motor versus sensory?
Very good question. I would say the yes, but with the caveat, the motor activation needs to target the motor nerve. Best target, I will present that later on, is the so-called motor point. And then something that triggers a non-tetanic contraction is more effective. That means anywhere from 1 to 15 hertz. After 15 hertz, the muscle becomes tetanic, and you don't want that. It's better that the muscle contracts at a rate that allows relaxation to be included in the cycle: contraction, relaxation, contraction, relaxation. So around 10 hertz, which is what I use with the Pointer Plus, I will demonstrate at some point, but targeting specifically a motor point or a motor nerve.
So there's a couple more technical questions like that. So during a typical treatment, how long should you keep an input in for?
Excellent question. Those are the main points that you have to polish. It's like cooking. Acupuncture is no different than many other qualitative activities. Like training and cooking are two perfect examples. So the dosage is something that's not written in stone, will depend. Sometimes I do 30 seconds, and that's all is needed. Sometimes I will select longer times. I have to explain each situation, but in general, you don't need a very long time of contraction to reset the circuit. It's like the phone. You turn it off, you turn it on again, 30 seconds, whatever the phone does, and then it works again.
Do you start with the improvement of the vasomotor control, then neuromotor, Or is there an order to your approach for each treatment?
There is an order that I will go over. Typically, segmental input is first. I go most of the time posterior primary rami because you want to get rid of the noise, so to speak, and that's best accomplished by a multi-segmental electroacupuncture input that I will illustrate, and together with some distal inputs, and that's the first part. After that, I go to the next part, and then I focus specifically on certain motor nerves, depending on what I'm trying to restore. So we will go through that process.
Okay. And sorry, can you go back and recap the part why an injury feels better with movement and worse once you stop moving?
Yes, because the number one neuromodulatory input at the spinal cord is signals, non-nociceptive signals that arrive to that segment. Children know this very well. If the child hits its elbow, what is the child going to do? Immediately, it's going to put the hand and it's going to feel better. Why? Because this triggers the stimulation of mechanoreceptors on the dermis that are thick myelinated fibers. And those signals, when they arrive at the spinal cord, they will trigger an inhibition of the entry of the nociceptive signals. And if you ask the child, okay, let me see, no, I'm not letting you because it hurt. And it's very true. The child is neuromodulating by touching. Same effect has the contraction of the muscle. So if you continue to move, it hurts. You know, the soccer player is there in agony. And 30 seconds later, you see the guy limping and then running. And they say the miracle water, that they gave him. But it's not the miracle water. It's the fact that activity from non-nociceptive neurons, when it arrives to the segment, it blocks the entry of
I see.
the nociceptive signals.
So then that blocking stops as soon as they stop moving
So
again.
you have to keep moving because if you stop, it's not going to be. And next day, of course, it's going to be painful because
Right,
you've already have less perfusion and you've suppressed those other signals.
right, right. When treating muscle tears, can you directly acupuncture the tear or should you stay away from it?
We can discuss that on the treatment of acute problems. You don't treat the tear because the tear is a non-entity. If there's a tear, it's a gap. You treat healthy tissue that surrounds the disruptive area because you want to facilitate the best metabolic activity in the area, control the edema, the vessels. You want the broken vessels to shut off, and you want the good vessels to open and allow blood. Uh, Good perfusion is not the same as hyperemia. So we can talk about acute, the techniques that I use for acute injuries in one monographic.
So this might be attached to that. What frequencies would be specific for stimulation of the sensory nerves? Is that the same 10 hertz or are you using?
No, obviously the sensory nerves, I said it in general, 2 hertz, 1 hertz. Actually, I put it to the lowest because 1 to 4, the effects are the same, and 4, it bothers you 4 times more because there are 4 signals per second instead of one. Um, there are no, the sensory nerves are not frequency specific. The frequency, the specificity is more related to the spinal cord and the supraspinal levels, not to the peripheral nerve per se. What is more specific is just to the type of a stimulus. So gentle pressure, vibration will engage different type of receptors. we can talk about that. So we had to review. There are many receptors, one for angular velocity, one for vibration, one for heavy pressure, one for temperature in the middle range, one for cold, or many for cold, more for hot, etc. It's a whole world of innervation, the sensory system.
Almost need a dictionary for all this stimulation.
That was the first book I ever bought when I engaged in medical school. Someone told me, buy yourself a medical etymological dictionary. And I listened, and that was very valuable. All I did is all day long learn where the words came from, and I learned more from the dictionary than from some of the other books I used. So I recommend that etymological dictionary.
Thank you so much. I think that's all the questions we have for today. This will be continued at a later date. So everyone again will get the recording, and thank you everyone for joining us on your lunch break. Oh,
Okay.
sorry, I missed one chat here. Um, uh, so somebody mentioned ligament treatment, ligament tears daily, sometimes twice a day. Curious if you're doing different treatments if treating on the same day.
Yeah, I would try and to cover different aspects that are valuable to accelerate the return to function. Sometimes you cannot treat the injured tissue because you cannot accelerate that. You can only optimize, but you can keep what's around in the best possible shape. So depending on the specific injury, I will include as many aspects, functional aspects of the kinetic chain as possible, not the injured area particularly. So yeah, I would do different things, different inputs.
All right. Thanks again, Dr. Elorriaga.
You're very welcome. I'll see you soon.
We'll be in
Have
touch
a great
soon.
day.
Bye.
Ciao.